Thank you all for joining us for this webinar today, which is part of our series of presentations being delivered on applying evidence in practice as part of the Comorbidity Project, which is funded by the Australian Government Department of Health. My name is Christina Morell. I'm a Senior Research Fellow and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. Along with Erin Madden, who is a Project Officer on the Comorbidity Project, I have the very great pleasure of facilitating this webinar today, which is being presented by Professor Katherine Mills and Logan Harvey. Today's presentation is the last one for this year, but we will be back next year with some more exciting presentations for you. So before we start, I would like to acknowledge and pay my respects to the traditional owners of the lands on which we're meeting, and of course recognise that we are meeting across Australia today. The traditional owners of the lands that I'm currently on are the Gadigal and Wangal peoples of the Eora Nation, but I would also like to pay my respects to other traditional owners of the lands across Australia for everybody else who's here. I'd also like to recognise and acknowledge the many people with lived experience of mental illness and substance use, as well as their families and carers, many of whom have generously contributed to the development of the comorbidity guidelines, as well as our other resources. I know that we're on Zoom and a lot of you are probably very familiar with how Zoom works, but just to quickly go over a couple of things before we get started. To let you know, firstly, that everybody who is here today, if you're watching the recording or live, you're in listen only mode, which means that we can't see or hear you. So just to draw your attention to the Q&A and chat buttons on your screen, please feel free to click on the Q&A button, type in any questions that you have at any time during the talk. We will have some time for discussion and we'll go through as many of those as we can. If you have any comments or anything that is not for either Kath or Logan, please use the chat. If you have any technical issues during the webinar today, you can contact Zoom support, or you can access the recording of the webinar, which we will be making available, as well as the PDF handouts of the slides from today. They'll be available for you to download from the website on your screen there in the next couple of days. If you find Zoom chat distracting, you can have a play around with the settings on your end to disable what messages that you see. And to do this, you just need to go to the Zoom desktop app. If you have it installed, click on the settings wheel in the top right-hand corner of your screen, and then select chat on the navigation menu. You should be able to change what messages that you see by changing your notification settings or even your do not disturb times, but it might take a little bit of fiddling around to get the settings right. So I've put the Zoom link to find out more information on screen, and you can have a little play around with it later. And I think Erin will post this link in the chat as well. So today's webinar is on trauma-informed care in alcohol and other drug settings, and I will be stopping talking in a minute and handing over to Katherine and Logan to get started. But before I do, I just wanted to mention that although this is our last webinar this year, we do have some more exciting webinars lined up next year, and you can find out more and also register for those at our website. The link to do that is on screen there. And thank you very much to everybody who's come along to our webinars this year, and also those of you who've presented and everybody who's given us suggestions for future webinars. We do ask for suggestions at the end of each webinar. So please let us know if you have any topics that you'd like to see as part of this series, and we'll see what we can do. And now it's my very great pleasure to stop talking and introduce our presenters for today, Professor Katherine Mills and Logan Harvey. Katherine is an NHMRC Senior Research Fellow and Director of Early Intervention and Treatment Research at the Matilda Centre. Her research focuses on improving our understanding of the relationship between mental and substance use disorders, evaluating innovative treatment approaches, and improving the translation of research into practice. In particular, Katherine's work focuses on the challenging area of post-traumatic stress disorder and substance use. Logan is an experienced clinician psychologist who has been working in specialist substance use treatment services for clients with co-occurring mental health and substance use conditions. Logan is currently a PhD candidate at the Matilda Centre, where his research focuses on the relationship between complex post-traumatic stress disorder and substance use. I'm so very glad that Kath and Logan could be here today, and I will now hand over to, I think Kath is going to speak first to get us started. Thanks, Kath.
Thanks, Chris, and good afternoon and welcome everybody. Delighted to be doing this presentation with Logan today for you, but I'd like to start by acknowledging the traditional custodians of the lands that we're meeting on today. For me, that's the Wangal and the Gadigal people of the Eora Nation. I'd like to pay my respects to elders past, present and future, and also acknowledge and welcome any Aboriginal and Torres Strait Islander peoples who are with us today. And would also just like to recognise and pay my respects to people with lived experience of trauma, substance use and mental health conditions. So we've been asked to talk on the topic of trauma and substance use, and the large number of people who registered for this webinar today is really indicative of this being an issue that's very close to people's hearts, either in a professional capacity or perhaps on a more personal note in relation to your own experiences or those of people who are close to you. We'll be talking quite broadly today about the issues that are up on the screen there, and we could easily talk about each of those for an hour, but we are just talking about them broadly. Even those broad conversations can sometimes be distressing for people and may affect us in perhaps unexpected ways too. So please feel free to drop in and out as you need to, or take a break. You can always download the webinar and catch up on it at a later date if you wanted to. And the team will also be putting some contact details up in the chat box, helplines and resources that people might find helpful if they do find today's discussion distressing at all. So, trauma exposure, that is any event where a person perceives that their own or someone else's life or safety is at risk, is unfortunately very common. Among people entering treatment for substance use disorders, trauma exposure is almost universal, with the most common traumas being witnessing serious injury or death, having been threatened with a weapon, held captive or kidnapped, or physical or sexual assault. There are also very high rates of childhood trauma, and people often go on to experience multiple and often prolonged traumas as well. Regardless of the type of trauma that a person experiences, whether it's a one-off event or something more prolonged, these events are life-changing and often lead to a person redefining their views about themselves, the world around them, as well as how they relate to it. For those who are unfortunate enough to have experienced trauma during childhood, these beliefs can then become particularly well entrenched. And the impact of those experiences, again, particularly in childhood or if the events have been prolonged, can be broad and long-lasting, including disturbances in a person's ability to regulate emotions, develop interpersonal relationships, their cognitions, memory, as I said, belief systems, which consequently can adversely impact upon a number of life domains. So whether or not a person's completes education, their employment prospects, as I said, their interpersonal relationships, also the likelihood of engaging in high-risk behaviours, experiencing imprisonment, homelessness, and also what we're very familiar with can lead to chronic physical health conditions, but also substance use and mental health disorders. In fact, childhood trauma has consistently been found to have a strong and enduring association with all classes of mental health disorders across the lifespan and across the world. The US Adverse Childhood Experiences Study has been really pivotal in improving the level of understanding about the impact of childhood trauma and adversity on the development and long-term outcomes relating to physical health, mental health, and psychosocial functioning. This was a retrospective study that was conducted in the 1990s in the US on over 13,000 adults. And what they found was that adverse childhood experiences like physical, psychological, sexual abuse, having parents with who are experiencing substance use disorders or experiencing mental illness, and parents who've been imprisoned, all of those events are associated with increased rates of alcohol abuse and illicit drug use later on, having an earlier age of onset of illicit drug use, as well as poorer mental health and higher rates of attempted suicide. And there's also a dose-response relationship observed, so that the risk of any of those things occurring and the severity of those does increase as the number of adverse events experiences increases. And a similar pattern has emerged from analysis of Australian National Survey data, showing that 1/3 of adults who reported childhood trauma went on to develop a substance use disorder, most typically alcohol or cannabis use disorders. But that rate is 3 times that of adults who have never experienced a trauma, and 30% higher than those who have experienced trauma, but only in adulthood. So given the high rates of trauma exposure and childhood trauma amongst people with substance use disorders, it's not overly surprising that we see high rates of post-traumatic stress disorder and PTSD among those who are presenting to treatment. In fact, up to 2/3 of clients of Australian substance use treatment services have been found to be experiencing co-occurring post-traumatic stress disorder when they enter treatment. And that rate is substantially higher than the general population prevalence, which is around 8%. Although PTSD is highly prevalent across all drug classes, it's most commonly observed among those with opioid, sedative, or amphetamine use disorders. So people with opioid use disorders, about 1/3 experience PTSD. For sedative disorders, it's close to 1/3, and people with amphetamine use disorders, about 1 in 4. So it's most strongly associated with those 3 classes of substance use disorder. And for 2/3 of males and half of all women who have both substance use and PTSD, substance use disorders and PTSD, the PTSD is typically develops prior to the onset of the substance use disorder. So despite PTSD being common and the symptoms are observable, but often they're actually overlooked in both substance use and mental health treatment settings, or they can be misattributed to other conditions or considered to be symptoms of intoxication or withdrawal. I won't go through all of the symptoms that I'm sure many of you are familiar with on the screen there, but I guess just ask you to remember that they are reflective of an adaptive response to fear that has become maladaptive. So responses that in the presence of a potential threat can actually keep you safe, like that hyperarousal and ability to fight or flee if necessary. But it becomes problematic when that alarm is being set off in situations where there is no threat. Also worth noting that for many people with substance use disorders, they can experience a more complex form of PTSD that's also characterized by what's referred to as disturbances in self-organization. So difficulties with affect regulation, having persistent negative beliefs about yourself, as well as persistent disturbances in the ability to form and maintain interpersonal relationships. Although there is a long history to this condition, it's only recently actually been recognised as an official diagnostic category by the International Classification of Diseases. And Logan, who's speaking after me, actually is conducting some of the world first research internationally looking at complex PTSD as the diagnosis is now among people with substance use disorders. And the initial findings from that work indicates that about 85% of those who would normally be classified as having post-traumatic stress disorder actually have it in its more complex form. So it's worth bearing in mind that although this isn't likely to surprise you necessarily, but the majority of people with substance use disorders who have been participating in these trials of looking at PTSD among that population group are likely to have actually had complex PTSD, not just PTSD. So for many people, self-medication plays a critical role in the development and maintenance of substance use disorder. So that postulates that the substance use disorder comes about as a response of repeated substance use in an effort to ameliorate or dampen those PTSD symptoms that a person is experiencing. So like PTSD itself, substance use has started off as something that is adaptive for a person, an adaptive coping strategy but it has become maladaptive with that repeated use. Unfortunately, while it might make you feel better in the short term, in the long term, it's associated with poorer outcomes. There are other theories to explain why substance use disorders and PTSD are so common in their co-occurrence. And one of the others is the high-risk hypothesis, whereby it's thought that the high rates of PTSD are driven by the fact that people with substance use disorders are at higher risk of trauma. So the more trauma you have, the more likely it is that you'll develop PTSD. The susceptibility hypothesis proposes that people with substance use disorders are more susceptible to developing PTSD following the experience of a trauma, either because they lack other coping skills to be able to deal with the event and process it, or in the sense that they may be physiologically susceptible from the perspective of having a dysregulated stress response system as a result of repeated cycles of intoxication and withdrawal that can predispose a person to going on to develop PTSD. But of course, there can also be a range of other common factors for both conditions, either biological, psychological, sociological, that might lead to their increased co-occurrence. But regardless of how both conditions come to co-occur, once a person does have both, each of those serves to maintain and exacerbate each other. And it's this reciprocal relationship that really underpins the impact of trauma and PTSD symptoms on substance use treatment. The studies that have examined how changes in symptoms of one disorder impact on symptoms of the other disorder have also shown that they're very integrally linked. So improvements in PTSD have been found to lead to improvements in substance use, but typically the reciprocal relationship isn't observed, or isn't observed anywhere near as strongly. PTSD symptoms typically don't remit following substantial improvements in substance use. And on the contrary, for some people, it is actually that they'll find that their PTSD symptoms tend to worsen once they start to reduce use or they stop using. And particularly those who have perhaps used it as, whether or not they're aware of it or not, if they've used it in some kind of self-medication role. So often people find that those symptoms may increase, and that does make it really difficult for a person to maintain abstinence or reduced use in the absence of any other coping mechanisms. So it really highlights the centrality of addressing PTSD in the treatment of clients who have both conditions. But also, in addition to the distress that's associated with the symptoms of substance use disorder and PTSD in and of themselves, people with both conditions tend to present to treatment with a poorer physical and psychological health and poorer psychosocial functioning, as well as having a more severe clinical profile in terms of their substance use. Often started using much earlier, have longer use careers, more extensive polydrug use, higher rates of suicide, and also higher rates of overdose. In spite of this, it's really important to note that both those with and without PTSD do typically demonstrate improvements across a range of outcomes in response to substance use treatment. But they can often continue to demonstrate poorer physical health, mental health, and poorer occupational functioning over the short term, and have consistently been found to experience higher rates of depression, attempted suicide, and experiencing subsequent trauma, as well as that lower rates of occupational functioning even over the long term. Which tells us that although substance use treatment services are doing an exceptional job at treating substance use in the presence of significant challenges, the disability associated with PTSD and other areas of functioning remains. So collectively, the findings from research examining the relationship between the disorders and the impact on treatment outcomes does highlight that importance of managing and treating PTSD among people with substance use disorders. And I will now hand over to Logan to speak more about the management and treatment of these conditions.
I'm going to talk a little bit today around some approaches to managing and treating trauma and substance use issues. Before I get started, I just wanted to acknowledge the traditional owners of the land I'm presenting from. That's the Gubbi Gubbi people. And to just pay my respects to the elders past, present, and emerging. So there's been some increasing advocacy for trauma-informed care, both in AOD settings, but also more broadly in mental health settings and elsewhere in health services over the past few years. And essentially, there's two key concepts that come into play when we're thinking about this. The first concept we're thinking about is trauma-informed care, and this really refers to those broad approaches we can take across multiple areas of a health service, in which we kind of can consider ways to design and adapt our health services to make them more inclusive of people with a trauma history and more sensitive and responsive to their unique needs. The second concept is trauma-informed practice, and this really refers to the provision of treatment activities related to trauma-related issues and symptoms. So typically this is the provision of evidence-based psychological therapy by trained and accredited professionals, but it's also an important area for non-clinicians to be aware of as well in terms of basic knowledge around treatment options and that treatment is available. So when we're talking about trauma-informed care, we're talking about essentially designing a program of care that will recognise the high rates of trauma in the population that we serve, and then adapt itself to provide a safe environment and service processes that can meet the needs of patients who have a significant history of trauma. Now, this refers to a lot of really broad things, such as the treatment environment, but also treatment processes. So it can come down to things as simple as waiting room design, what your clients walk into when they walk in, where they receive their treatment, what rooms are like, where they're located, how they're designed. And it can be things like what sort of magazines are left out in a waiting room, what's on the TV or the radio. And then it can go right through to things like our treatment procedures, what we require of clients, the processes they have to go through in order to access treatment, and the ways in which they access treatment. And a big part of this is about considering options for flexibility when some of those processes may actually be distressing or upsetting or just increase pressure on someone who's already dealing with some trauma-related symptoms. The whole goal of this in the long run is to create a treatment environment that's going to be more healing and less re-traumatizing. More broadly for the AOD workforce, this would really involve all clinicians and staff in an AOD workforce having an awareness of the extent of trauma exposure among clients presenting. So the extent of how many people are being exposed to and the severity of trauma that people are being exposed to. Understanding then the consequences of that exposure and its impact on treatment and treatment engagement and recovery. And then importantly, being able to recognize the signs and symptoms of disorders like PTSD and other trauma-related disorders. And this is a really important aspect of this, that often we find that people are fairly aware of trauma exposure in general, probably not to the extent of it, but that kind of flow-on effect in terms of how that might impact treatment, and importantly, what sort of symptoms and issues that might lead to, that's often missing. And so being able to integrate all of those aspects into a client's treatment would be a good start for any trauma-informed care process. Now, we could talk about trauma-informed care for the whole webinar today, but we're going to move on to some other things. So I just wanted to put some resources up here on the screen for anyone who is interested in finding more about this. You can follow up on these resources. There's some international and national ones there that will give you a sense of the ways in which other people have adapted trauma-informed care for substance use settings, but also more broadly how it's been adapted in mental health settings and other services. This is a really good example of a really simple thing that we can implement in our treatment to kind of increase our trauma-informed care and practice to an extent. So this booklet on screen now is one of a series of booklets designed by the team at the Matilda Centre, which look at different areas of comorbidity with substance use. So this booklet provides evidence-based psychoeducation around trauma-related issues. and substance use. And it's a really nice way to provide a client with some good information that can help them start to look at their situation a little. So this is something that can be incorporated into assessment processes and things like that, and give you a really good sense of where to start in terms of talking about some of these issues with a client. It can be a good start point in terms of acting as a stepping stone for clients as well. First, to get an understanding of what some of their symptoms actually are, and then to kind of think about, well, what might they need and what sort of treatment might they be interested in. Once we move into thinking about treatment activities, we're moving into that area of trauma-informed practice, the idea of how we treat trauma-related issues. Traditionally, in substance use settings, there was a major hesitancy to provide any trauma-informed treatment and trauma-focused treatment. Now, a big part of this was related to the idea that AOD clients are too vulnerable, that they perhaps have too complex an issue, and that we need to address the AOD issues first. Traditionally, this was in the form of requiring abstinence before any kind of PTSD diagnosis or management would be considered. And the general idea here was that if clients are still using substances, that doing any kind of trauma-focused care will lead to some sort of exacerbation in their substance use. They're going to start using a lot more, potentially drop out of treatment and end up with a worse result. We've got some good evidence now that ongoing substance use during treatment will impede the flow of treatment. It might slow it down, it might make it slightly less effective, but it's not necessary to achieve abstinence before this sort of treatment can start, and improvements can definitely be made even if there is ongoing substance use. So there's three models that we tend to talk about in terms of how we address these comorbid issues. The one traditionally that was most popular was this sequential model, the idea that we do the SUD treatment first, and only once their substance use is resolved, typically by abstinence, but some people would look at more of a reduced and then stabilized approach. Only then we move on to PTSD treatment. The parallel model is an alternative to that. And what that looks at is for two different clinicians to be providing treatment in the two different clinical areas. So essentially a client would engage with separate clinicians, one for substance use and one for PTSD. Often this is done in different services. So they might engage with a substance use treatment service and also a private practice therapist or a mental health service clinician. And there's a few kind of issues that can come from this. It does seem logical that we'd have two different people with different focuses and that they'd focus on those areas separately. But when you're working with people, what tends to be really tricky is to tease out these issues. The reality is it's very difficult to talk about substance use without talking about trauma and vice versa. So practically there are some hiccups that can come up there. And then practically the other issues that come up are to do with having clients move between different clinicians. Now, often if they are going between different services, there'll be different service rules and approaches, there'll be different availabilities and timings. So being able to tee all of that up so that they can engage in these treatments at the same time is really complex. But often there'll be different rules and approaches by different services, even clinically. So they may be getting very different types of advice and intervention in different services. This can create a general sense of confusion for a client, but also it means that they're forced to move between services, and the chances then of something going wrong, of them feeling inadequately supported, are very high. The result of that then is that people often can fall through the cracks, and they end up essentially getting no treatment from either service. The model that we prefer and recommend is this integrated model, the idea that both issues can be treated at the same time by the same clinician in one episode of care. We've got some good evidence now that clients tend to prefer this and that it's actually more efficient. And it's a nicer way to address, I guess, the whole person, all of the issues they're presenting with, and also to conveniently address all the issues. When we're talking about the evidence base for integrated psychotherapies, we tend to talk about two different types of psychotherapies. The first are present-focused therapies, and these really focus on developing skills and strategies to cope with symptoms without delving into the trauma or discussing the trauma. So the idea here is that we would teach clients skills and strategies to manage their symptoms in the hope that once they can more actively and effectively manage their symptoms, that their problems will remit to some extent. The other option that we have is past-focused therapies, or what are often called trauma-focused therapies. And these therapies are about addressing the trauma directly. So working with the trauma memory, the memory of what happened, in a way of resolving that. When we look at the current evidence base, based on a series of recent reviews we've had, we can see that the evidence really suggests that individual past-focused therapies delivered alongside AOD treatment can reduce PTSD severity and substance use, but there's not as much evidence that the present focused therapies are as effective. Traditionally, the main way these past focused therapies were delivered was via exposure therapy techniques. And this is really because exposure therapy has long been the gold standard in treating PTSD. It's the therapy we've had the most evidence for the longest. And so these were more readily adapted to substance use settings. In short, these therapies are all about exposing a person to feared stimuli related to their trauma. So we have them approach the feared stimuli in a really safe way under certain settings and circumstances, as a way of addressing those avoidance symptoms that are really the hallmark of PTSD. We can do this in vivo in terms of addressing stimuli in their environment around them, people, places, situations that they've avoided. And this can be things like crowds and busy places, driving in traffic, more often, hearing about reminders of their trauma via news articles or things like that. And then the other approach we take is through imaginal exposure. And this is where we're looking at exposing the person to their trauma memory. So we do repeated and prolonged episodes of exposure to the trauma memory. And over time, that leads to extinction of that fear response. The memory becomes less distressing. The client's better able to discriminate between past and present. So that trauma memory feels like an old memory, not a current memory. And then once that kind of happens, the memories become a little more organized, and typically the maladaptive beliefs associated with it tend to be reprocessed and become slightly more adaptive. Now, exposure therapy was definitely considered inappropriate for people with substance use in the past for some of those reasons we've talked about just before. But we have evidence now that suggests that's not the case. We have a number of studies now that really show that it doesn't lead to any exacerbation of substance use or the severity of a substance use disorder. And there's some evidence that engaging in exposure interventions can actually have a protective effect against relapse. The other big issue that we often saw was this sense that if people with substance use issues engage in exposure therapy, they will drop out of treatment. But again, over a big series of studies now, we can see there's no evidence of increased attrition when these sorts of interventions are used. So we have a good sense that these interventions can be adapted. They don't tend to exacerbate the comorbid issues, and they don't tend to lead to dropout, which is great news. Now, there have been some of these trials conducted in Australia, which is also really good. So we've got some local evidence to help support us here. The first study there is a really good example of the sort of results we can get. So that study found that participants who had received one or more session of exposure, and that's one or more sessions of exposure, exhibited a twofold greater rate of clinically significant change in PTSD compared to those who were only getting supportive counselling. So that's a really interesting result, because it tells us that we don't even need a lot of this exposure therapy necessarily to get good results. Even a small amount will tend to be useful. The second study listed there was conducted by Kath, and this was a large trial of a treatment called the concurrent treatment of PTSD and substance use disorders using prolonged exposure, otherwise known as COPE. And this is a treatment package that was initially developed in the 90s by colleagues in the US at the Medical University of South Carolina, and which Kath has then done a lot of work on and adapted and trialed in Australia. So this is a 12-session treatment program. It incorporates prolonged exposure targeting the PTSD along with some CBT for substance use. So there's a manual there that's been published, both a therapist guide and a client workbook as well that you can get for this package. So it is very neatly organized at this point, and it's a really good example of the type of therapy we can use here. These are some of the results that Kath achieved in her initial trial of this back in 2012. And it shows some important things. One is that if you look at the outcome here, individuals engaging in standard kind of substance use treatment still had some good effect of both areas of symptoms, both PTSD and substance use. So we have a sense that engaging in substance use treatment in general can be helpful here. The important result there we can see, though, is that by adding in COPE, we can get a magnified effect. So that provides even more benefit. So something as simple as this sort of 12, 13 session program can add a significant value for clients. And those effects are really maintained up to 9 months there, which is also very important. The COPE program has been trialed all around the world now since Kath's trial. In a variety of populations across veterans and community samples in different countries, and has found good results everywhere it's been trialed. So that's really encouraging for us as well. Kath is also conducting another trial at the moment of a modified version of COPE for adolescents and young adults. And so this is going to give us some really good information about how we can apply this sort of intervention for a younger population. Now, we know then that these exposure therapies tend to have pretty good outcomes in this population. There have been some broader studies done in other types of trauma-focused interventions. So there is another study listed up here that also used prolonged exposure, but combined it with the motivational enhancement therapy, and similarly got some quite good results. And there have been 2 small trials looking at different interventions mixed with EMDR, eye movement desensitization, and reprocessing, which is another evidence-based treatment for PTSD. So again, those EMDR trials found some good results as well. Cognitive processing therapy has also been used in this population, and the study listed there combined cognitive processing therapy with CBT for substance use disorder. And again, that's kind of similar to what COPE does with prolonged exposure. And again, they found some really good results as well. There are some ongoing trials there addressing a variety of interventions. If anyone is interested in looking more into those, we're hoping those will give us a bit more evidence of some of the broader types of treatment we can use in this population too. Now, we know from all of those trials that these sorts of interventions can be effective for comorbid PTSD and substance use, but one of the questions we're kind of wondering about now is, what does that mean for complex PTSD? Now, unfortunately, there's very little evidence published to date on complex PTSD treatment. And that's purely because it is a newly established diagnosis. And so there just hasn't been the time to get those trials happening. We know as well there's probably going to be a bit of a lag in terms of once there's some initial evidence established for the treatment of complex PTSD, looking at that in a comorbid way with substance use disorder will probably take a little bit of time as well. But we've got a good kind of background level of evidence around addressing complex trauma and complex PTSD symptoms that we can call upon here to help us kind of get an idea of what might be useful. So traditionally, when we're talking about complex PTSD, there's been this idea that people with complex PTSD are going to require additional and alternative treatment approaches. So they're going to require more treatment in different ways. And mostly this is talked about in terms of a slower pace of therapy and a longer introductory period to therapy involving stabilization of symptoms before we would look at any trauma-focused interventions like exposure or EMDR. This has been looked at in a number of recent studies, though, in the PTSD literature, looking at populations who have childhood-related PTSD and things like that. And we can tell by those trials that actually we don't need to necessarily add stabilization phases or additional treatments. If we apply these trauma-focused interventions well, they tend to be effective for people with complex trauma. And this also relates to things like dropout rates and adverse events. Overall, these trials tend to show that whether or not we add in a stabilization phase or we add in extra skills training and things doesn't tend to have much of an effect on outcome. And we can get pretty similar outcomes just by directly targeting the trauma-related issues. So that's really handy for us to know that there's reasonable evidence developing there that we might not need to add too much more into our treatment here. The way we're talking about treatment of complex PTSD at the moment, though, is in terms of multi-component or modular treatments. And these are really being suggested as a way of addressing those additional symptoms of complex PTSD and thinking about how we might individualize treatment for complex PTSD. The idea here would be that based on a person's presenting symptoms and which symptoms are most problematic for them, we would add in modules of therapy targeting those particular symptoms. So if we're thinking about the current kind of situation, then we know that these kind of PTSD symptoms that the ICD-11 defines have got some pretty good evidence for existing treatment models. And so we can apply those to treat these sorts of symptoms. If we look at the literature as it stands, we know that we've also got some good substance use disorder treatments. And then if we put these together with the PTSD treatments, again, we can get some pretty good results. And we also know that targeting the PTSD symptoms tends to give us a good impact on substance use disorder symptoms as well. And so when we think about complex PTSD, we're just adding in a little bit of extra complexity and a few more symptom categories. So the question that will need to be answered in the next few years is, what sort of treatment do we need to add in here? We already have treatments that target those particular symptom clusters, and there has been some research which shows that some of the existing PTSD treatments will have an effect on those symptom clusters, but we just need to get a little bit more evidence to be certain. In short, though, we just need to be thinking as clinicians about individual clients. And if a client has significant issues with affect dysregulation, just being clear that we might need to add in some additional treatment activities targeting that. So some general tips then in terms of how we might implement these trauma-focused interventions. The first thing that I'd point out is that some trauma-focused intervention is better than none. We saw in the some of that research that even 1 or 2 sessions of exposure therapy can double the chances of a clinically significant change in PTSD. And we have a fair amount of evidence that points in this direction from different trials for PTSD. If we can target these interventions well, choose the issues that are most problematic for clients, we tend to get pretty good effects. And really, these are the interventions that should be prioritized because those are the ones that get the biggest and most robust treatment effect. So this doesn't mean that we need to add in years of therapy for clients. It might mean that we add 13 sessions like with a COPE program, or it might mean that we add a few sessions of exposure in amongst our existing treatment. Now, we do have the most evidence for exposure-based therapies, but we also know that the evidence base is expanding, and we have lots of other evidence-based treatments for PTSD. So things like EMDR, cognitive processing therapy, these therapies have good evidence for PTSD in general, and we don't have any indications at this point that they can't be applied in a substance use treatment setting. So there's nothing that says that we can't use them. We just have to be conscious of each individual client and what kind of approach will work best for them. A big part of that, obviously, is that these sorts of therapies do require training and supervision, and that there is kind of an investment there on the part of clinicians and services to make sure that they can be implemented well. We also know that trauma-focused interventions alone will likely have a positive effect on substance use. And this is a really unique finding of some of the studies that even engaging in these trauma-focused interventions targeting PTSD, if we can get some movement on the PTSD symptoms, we tend to see a corresponding effect on substance use. And so that's really nice for us to know as well, in that even if we are not able to fully target every aspect of a person's substance use and put them through a full relapse prevention program or something like that, targeting these PTSD symptoms will likely have a good flow-on effect to their substance use symptoms. And related to that, then, we also know that we don't need to wait for abstinence now. We've got enough evidence now that tells us that actually at the point of engagement, unless someone is acutely withdrawing or unless they've presented acutely intoxicated to the point that they can't talk with you in therapy, there's probably a reasonable chance that they can engage in some of these interventions. That is going to be specific to clients, and we do always have to adapt these treatments to specific clients. But in general, we know that ongoing substance use isn't too much of a problem, and that we just need to work with our clients around moderating their substance use around treatment sessions and things like that as best we can. So to summarize, we know now that trauma exposure and PTSD are really common occurrences in AOD populations, and they do have really clear effects of harm and poorer treatment outcomes in this population. We have a mountain of evidence that's built up showing us that, and that has, I guess, been a real stalling point for treatment for a long time. We do now, though, have a growing body of evidence that tells us that actually we can be quite effective in our treatments in this area, and that there's probably a lot of hope around that. Some challenges we need to look at are around stemming the flow of the chronicity of this illness. How do we intervene earlier and build resilience in young people? And then the flow on from that is how do we then incorporate these kind of treatments into practice so that they can be given earlier, and that we can move from doing trauma-informed care to really trauma-focused treatment activities, because that's going to be a big part of this. All right, thank you all for listening, and I think we might hand over for some questions.
Thank you so much, Logan and Kath. That was fantastic. And we have had some questions that have come through and do have a little bit of time to go through them for a change. So I am going to get us started off by asking Logan the first question, which is about complex PTSD and PTSD. And I know that you and Kath had both spoken a little bit about some of the differences between complex PTSD and PTSD, but I was wondering if you could maybe comment on what a clinician might expect to see in terms of some of the differences in how a person might present to treatment if they are experiencing complex PTSD as opposed to PTSD.
Yeah, one of the I guess one of the big issues with that is often when people are presenting with complex PTSD, it won't be immediately apparent. And one of the reasons for this is that because of those additional symptoms, we often don't necessarily see things like flashbacks and re-experiencing symptoms that are real classic PTSD symptoms. So we notice things like some emotional dysregulation and relationship issues and things like that. And we don't immediately then think of trauma and complex PTSD. We tend to go down the pathway of other diagnoses. So I think you may notice that a client with complex PTSD does have very intrusive re-experiencing symptoms, but often we will actually see the other side of it first. And unfortunately, then often these people don't end up getting a true understanding of their symptoms and a diagnosis. It can work the other way as well, though, where we may see that they have some of those classic PTSD symptoms, but the full complexity of their symptoms isn't recognized because they're considered comorbid issues or other issues. These are other things going on, or these are situational, or this is related to their substance use, as opposed to looking clearly at the full picture.
And do you think that, just the follow-up to that, I guess, as it's a relatively new diagnostic category, I wonder whether in the next few years we'll see more of an understanding about complex PTSD and I guess how it relates to a person and their other disorders or conditions.
I think so, definitely. I think we're already seeing that in the clinical world a lot more now. We're seeing people take a broader lens to trauma-related issues and not just immediately search for those classic PTSD symptoms, but to screen for trauma exposure and then look at symptoms in general to get a bigger picture of what's going on. And I think that'll be the real kind of turning point. We'll start to really notice the extent of this from there.
And I saw that you'd also put a link to the International Trauma Questionnaire, the ITQ, in the Q&A box, which is really great. Thank you for that.
Yeah, no, that's a great instrument, and it's free. It lines up with the ICD-11 diagnoses as well, and they also have a corresponding trauma exposure measure called the ITEM that's available for free on that website as well. So they're great clinical measures that are free there.
Thank you. I will ask Kath a question now. Kath, I wanted to ask you about COPE-A, which Logan mentioned. First of all, why did you decide to do COPE-A? How has it been running this trial during COVID? And lastly, are you able to talk about any preliminary findings or any key themes that are emerging? Just a triple barrel question there.
Sure, I'll do my best. Yeah, so the current trial that we're doing is looking at a modified version of the program that we've evaluated for adults, and that has been researched more extensively, modifying it to meet the developmental needs of adolescents and young adults. And the reason that we decided to go down that line was because there was still really little evidence about how you treat these co-occurring conditions earlier on. And from the adult trials, not just ours, but other trials, but as for example, the average age of first onset of trauma exposure was 8 years of age. So, and similarly, substance use around the same time or shortly afterwards. So that's often a long lead-in time before people actually end up in treatment services as adults. So we wanted to see if we could potentially, I guess, provide clinicians with some level of evidence or guidance about would this approach also be useful among the adolescents and young adults that they're seeing. Can't give you any outcomes at the moment just because the study is still underway. And I'm very pleased to say that we have just started recruiting again after our second lot of pausing due to COVID. So very happy if people want to know about that to get in touch with me as well.
Definitely have to have you back, I think, to talk a little bit about those findings then at some point. Have had some more questions come through, and one from Gillian, who I think is joining us from Canada. Hello, Gillian, who has a question about if you have any advice from for an outpatient program with limited individual treatments, so 5 sessions total, and the majority of care is done via groups for young adults. They thought about using Seeking Safety, but have limited evidence. Given the limited evidence, they didn't implement it, so they have a gap in trauma-focused care. Sorry for butchering that one, Gillian.
Which one of us would you like?
Oh, well, feel free, both, either.
All right, I'll jump in, but Logan, you can follow up if there's anything to add as well. Just on Seeking Safety as well, in that question, I think it's important for us to realise that the exposure-based programs or the other types of past-focused treatments that are being developed and looked into, they're not the only option. It shows that, yes, they are currently what looks to be better treatments in terms of reducing distress and the PTSD symptoms themselves. Seeking Safety is excellent in terms of engagement with participants and improving a number of life domains. It's just that it's not really, I guess what the evidence is showing is that it's not, you don't seem to see that shift in PTSD symptoms themselves unless you're doing those past-focused, trauma-focused therapies. And also just to say that I don't think necessarily all services are going to be able to treat PTSD to the same degree. So it might be that when you do have those shorter programs, that it is that you are working on things like establishing safety and really opening the door for that person to the option and the prospect of in the future, potentially doing more intensive work through other programs.
Thanks, Kath. Yeah, and sorry, I should have said before that we just acknowledge that we do have a lot of questions here and we probably won't have time to get through them all, but are you both happy for people to contact you with any follow-up questions? And Erin, would you mind putting Kath and Logan's email addresses in the chat for people?
Yeah, very happy.
Thank you. So a question about whether either of you know of any, sorry, Logan, did you want to add anything to that question before I close it off?
No, I think Kath covered it well. I think, yeah, and then in short treatment bursts like that, I think our best options are education and maybe some skills and really getting a client to the point where they can recognize what the issue is and that there is treatment. Then it becomes a stepping stone approach, really. And those trauma-informed care principles, I guess, are very important in a situation like that.
Yeah, thank you for putting those up. I'm talking them through. So a question about whether you know of any culturally validated PTSD screening tools for Aboriginal and Torres Strait Islander people or Aboriginal communities.
So I am aware that there's some research that's being conducted in Queensland at the University of Queensland by Marie Toombs, which was looking a little bit at some of this, but I believe they were primarily using interview-based measures. And I don't think at this stage there have been any studies looking at the kind of complex PTSD symptoms and things that I'm aware of anyway.
So potentially some coming out soon.
Fingers crossed, yeah. I think more broadly, the so the ITQ and the measures like that have been developed for the ICD-11. The World Health Organization is very big on the ability of those measures to be applied anywhere, and so they have been translated into a huge number of languages and validated in a huge number of settings. So we have some pretty good sense that they're probably useful in different populations. It's just about whether they're going to meet particular populations. We don't have all the evidence yet.
Yeah. Okay, thanks, Logan. Do you know of any referral organisations in Sydney for adults who are experiencing alcohol and other drug issues if the clinician is only able to provide PTSD treatment?
Give that one to you, Logan.
Yeah, it is a tricky one. I guess, you know, all health districts will have their local drug health or drug and alcohol services, but they do vary, I guess, in how much treatment they provide and the types of treatments they provide. But I think in general, contacting the local service will give you a sense of what's in the community, or otherwise contacting ADIS, the Alcohol and Drug Information Service, because ADIS has a good database there with a lot of information that might be able to point you into a more specialized direction.
Thank you. And I've just seen that Rebecca has put something in the chat about some more information on trauma in First Nations. Thank you. I'm just trying to monitor several different things at the same time. I'm sorry for being a little bit slow, everyone. A question here from Stu asking about whether you can explain a bit more what CPT is. Wondering.
Also a good one for Logan.
So cognitive processing therapy it's a trauma-focused treatment that is built on cognitive therapy in general. So it's a structured, manualized program with set modules that you move through, and it's all about understanding the kind of ideas and the maladaptive beliefs that have developed post-trauma. So you move through the progression of these modules, examining the impact of the trauma and the event, the meaning behind it, and helping a person kind of reappraise it and therefore think about it differently as they move forward. So there's good evidence for that. It's been applied a lot in veterans populations in the US. There's some nice online training packages, one of which is free, like an introductory kind of webinar-based training. And also there's a really great manual that they've published of that as well.
Thank you so much, Logan. Always a fountain of information about all these important things. A really great question from Kylie asking about intergenerational trauma for our First Nation people, whether that is considered PTSD.
Yeah, it's an interesting question, because I think we can often, you know, especially with the diagnostic systems, get kind of a bit caught up in what's classed as a trauma sort of thing. And I guess the fundamental thing is whether or not whatever a person has experienced or is experiencing because something has happened to them, where is it causing issues for them in their life, and what kind of symptoms are they displaying, and therefore what kind of treatment is likely to be most beneficial to them at a particular point in time. My personal perspective is probably that it's probably a bit more complicated than just a simple PTSD diagnosis itself.
Thank you. And I'm aware that we haven't gotten to everybody's questions, and it's now 1:30, so I will wrap up. But if you are able to send through your questions that are remaining to Katherine and Logan, then they will be able to answer those, and I'm very sorry about that. So just before we quickly wrap up, I wanted to quickly put up information on where you can access the comorbidity guidelines that we have mentioned, which is what this series is all about, or which is where this is really stemmed from. And you can access information about those on our website, as well as the recording from today and the slides from today. I just wanted to thank you again to everybody who has joined us for the webinar. If you're interested in looking at the recording or registering from our upcoming webinars, looking at our previous library of webinars, you can do that at that website there. And just want to all let you know that we have a really exciting webinar coming up in February, and that will be Dr. James Gooden and Dr. Vanessa Peterson, both from Turning Point in Victoria, and they're going to be presenting on supporting AOD clients with cognitive impairment. But until then, thank you again for joining us today and taking part of the series this year. Thank you so much, Katherine and Logan, and please enjoy the rest of your day. Stay safe over the holiday break, and looking forward to seeing you all next year. Thank you.
Thanks, everyone.
Thanks, everyone.